Good afternoon, everybody. My name is Chris Florkowski. I am a consultant in chemical pathology at Canterbury Health Laboratories in Christchurch, New Zealand. Today we are going to talk about Porphyria with a focus on a number of case studies and with an emphasis on interpretation. This is what many clinicians look like when you mention the word Porphyria, or indeed many laboratorians. Porphyria is a rare condition or group of conditions that many clinicians will never encounter in their working lives. But they are out there, they do exist, and it is important to have some concept of the condition and how to investigate. Porphyrias are inherited disorders of heme synthesis, heme being an important component of hemoglobin and the cytochrome system in the liver. The conditions arise when there is an enzyme deficiency at any number of sites in the pathway leading to reduced formation of heme. As a result, there is reduced feedback inhibition of the pathway, leading to increased activity and accumulation of porphyrins or precursors proximal to the block. So when the precursors are present in excess, and by precursors we mean ALA or aminolevulinic acid, or PBG, porphobilinogen. When the precursors are present in excess, the clinical features are predominantly neurological and or psychiatric. On the other hand, when porphyrins are present in excess, the major clinical feature is photosensitivity with or without a rash. So the heme synthetic pathway commences with the combination of glycine and succinyl-CoA, proceeding through a number of enzymatic steps through to the formation of heme. So for example, ALA synthase is responsible for the formation of ALA, ALA dehydratase for PBG, and so on through the pathway. A number of the steps occur within the mitochondrion, and these are enzyme activities that are very difficult to measure and generally inaccessible. A number of the steps occur in the cytosol, and some of the enzymes can be assayed as part of investigation. Each one of these steps, when deficient, corresponds to a particular porphyria type. And this is a slightly simplified version of the pathway, easier to remember: precursors through to heme and corresponding enzymatic steps and the corresponding disorders. So the porphyrias may be thought of as acute or chronic. The least uncommon of all the porphyrias is Porphyria cutanea tarda, which is under the category of chronic porphyria. The acute porphyrias include acute intermittent, variegate, and hereditary coproporphyria, and all are characterized by raised urine porphobilinogen in the acute attack. Other chronic porphyrias include the photosensitive Erythropoietic Protoporphyria and the very uncommon chronic Erythropoietic Porphyria, although there have been cases including Sri Lanka. So the clinical scenarios for investigation include acute symptoms. This can be abdominal pain, neurological features, or psychotic. And in particular, in abdominal pain, there may be a consideration for surgery, and mindful that certain drug categories used in anesthetic induction can potentially make an acute porphyric condition worse. So diagnosis of the acute condition is important. The other scenarios for investigation include photosensitivity and or skin rash. And the third, more challenging scenario is family screening. So in a single slide, this is all that clinicians need to know about porphyria. Urine PBG is the most important test. Urine porphobilinogen. If this is negative at the time of any acute symptoms, then those prevailing symptoms are not due to acute porphyria. So urine PBG, the single most important test. Secondly, if porphyria is genuinely suspected, then it is important to send all samples, urine, feces and blood, to the laboratory and protected from light. Here is the case of a 48-year-old male who presented with abdominal pain, constipation 1 month after starting phenytoin treatment for a generalized seizure, also insomnia and anxiety. He was hypertensive with a significant postural drop and had a marked tachycardia. He had a hyponatremia, and it was questioned whether this could have been contributory to the seizures, and the findings of inappropriately concentrated urine with natriuresis suggested that he may have an underlying syndrome of inappropriate ADH secretion, although arguably with the increase in urea and the observed postural drop, he is not strictly euvolemic. On CT scan of the abdomen, he was found to have an intussusception. So that is a folding of the small bowel back on itself. And it was questioned whether this may have been partly related to his abdominal pain. And on CT abdomen, following IV contrast in the nephrogram phase, he was also shown to have a small renal infarct, which could also have been significant. Intussusception resolved on repeat CT scan. His abdominal pain gradually resolved, and he underwent further investigations for hypertension. This included a 24-hour urine collection for metanephrines, which his wife observed to have darkened on standing in the collection bottle during the 24-hour period. So it looked something like this, and immediately it was questioned whether he could have a porphyria. Urine PBG screen using Ehrlich's reagent was strongly positive, and his urine porphyrins were also markedly raised. A positive urine PBG screen is very specific for acute porphyria and usually indicates one of acute intermittent porphyria, variegate porphyria, or hereditary coproporphyria. Raised urine porphyrins, on the other hand, may indicate an underlying porphyria, but can be secondary, in particular coproporphyrinuria, and in relation commonly to cholestatic liver disease, but also lead or other heavy metal poisoning and some hematological disorders. So having shown positive initial tests, his ALA and PBG quantitation were markedly raised, and he was also shown to have markedly elevated fecal porphyrins. Fecal porphyrin elevation may be seen in some normals attributable to bacterial contamination, but very unlikely at the high concentration seen in this case. It can be supportive of porphyria, and of the acute porphyrias, raised fecal porphyrin is not typically seen in acute intermittent, so this narrows the diagnosis down to variegate or coproporphyria in the current case. GI hemorrhage can also cause elevation of fecal porphyrins. On the fecal porphyrins, we can do HPLC fractionation, and we can identify metabolites, and in this case a marked elevation of the deuteroporphyrin peak, which is consistent with variegate porphyria. The other approach is fluorescence of the plasma, which is commonly seen, in Porphyria. And in this case, we are taking plasma. We are using an excitation wavelength of 400 nanometers and scanning the emission wavelengths. And in this case, demonstrating a peak emission at a typical peak of 626 nanometers, which is typical of Variegate Porphyria. So this is as a result of porphyrins being attached to plasma proteins and exhibiting fluorescence. So this is the Haem synthetic pathway showing the cytosolic steps and the mitochondrial steps. And in this case, in Variegate Porphyria, the block is here at the level of protoporphyrinogen oxidase, otherwise known as PPOX. At the time, we sent DNA away for analysis. Currently, we undertake all genotyping in-house, but at this time, we had a report back showing a 23 base pair deletion in exon 5, which was a known mutation in the PPOX gene and consistent with Variegate Porphyria. So this is the index case that I have just described, and other family members underwent cascade family screening, and one son was found to have the 23 base pair deletion in the PPOX gene, and 2 sons were unaffected. So this affected son had been clinically unaffected by any porphyric symptoms, although he is identified as being at risk if he is exposed to any number of drug classes. So he has latent as opposed to acute Variegate Porphyria. So the illustrative points of this case are a number of the typical presenting features, including hypertension, tachycardia, constipation, hyponatremia, arguably attributable to syndrome of inappropriate ADH secretion, being latent or symptom-free until later life, the role of precipitating drugs, such as phenytoin, maybe by inducing the cytochrome system and demand for heme. Next is the possible role of autonomic dysfunction in abdominal pain as part of the porphyric condition, and with presenting features including intussusception or renal infarction, postulated to be secondary to intense focal vasoconstriction. And finally, the role for genotyping, cascade family screening, and genetic counselling. So Variegate Porphyria is characterized by acute episodes with or without photosensitivity, raised urine PBG in the acute attack, raised urine and fecal porphyrins with typical metabolite profiles on HPLC, reduced activity of the enzyme PPOX, although this is not one that is easily measured, and the presence of mutations. In fact, there are well over 100 different mutations described, and in certain populations, such as the South African Afrikaner, there is a common founder mutation called R59W that we can test for in Afrikaner patients presenting in this way. So with respect to founder effects and common mutations, it's postulated that the gene for Variegate Porphyria was introduced into South Africa in 1688 by 2 Dutch settlers who arrived in Cape Town. So R59W accounts for 95% of PPOX mutations in South Africa, with an estimated 6,000 plus affected, and the gene prevalence there is in the order of 1,200 per million in that population, compared with 7 per million in other Europeans. Acute intermittent porphyria, on the other hand, presents with acute episodes such as abdominal pain, neurological features or psychotic episodes, but typically no photosensitivity, and fecal porphyrins are normal. As with VP, it can be precipitated by drugs, inducing cytochromes, increasing the demand for heme, and it's also associated with use of estrogens, oral contraceptive pill, and often with an exacerbation of symptoms perimenstrually. The gene prevalence is thought to be about 1 in 100,000. It is an autosomal dominant condition, but with very low penetrance. So over 90% of those who carry an abnormal gene will be unaffected throughout life and thus latent. So the disorder may also appear to skip generations. So acute intermittent porphyria, AIP, urine PBG is raised in the acute attacks and may be elevated between acute attacks and the latent phase. In AIP, the urine darkens on standing due to oxidation of PBG to porphyrins. Fecal porphyrins are usually normal, and the key enzyme affected is PBG deaminase, which in some settings has been used as a screening test for latent AIP. So this is where PBG deaminase sits in the Haem biosynthetic pathway. So whilst PBG deaminase has been used as a screening test, there is overlap between affected and normals. Reduced levels are supportive of AIP, although some normals may have reduced levels and some affected may have normal levels. So it is not a perfectly discriminatory screening test. Another problem is that you can have patients with good clinical and biochemical AIP but normal PBG deaminase activity. And this arises from the fact that the PBG deaminase gene shows erythroid and non-erythroid promoters. There is an erythroid form of PBG deaminase which normally lacks exon 1 due to alternate splicing. So mutations affecting exon 1 can lead to reduced liver enzyme activity and thus the clinical condition, but don't affect the erythroid form, thus PBG deaminase activity is normal. Acute intermittent porphyria is sometimes known as the Swedish type, and there is a dominance of a particular founder mutation in the gene PBG deaminase, which has a prevalence of around 1 in 1,000 in northern Sweden, and with a particularly high prevalence in a village in northern Lapland. So acute intermittent porphyria, again, founder effects and common in certain parts of Sweden. At this point, I would just like to acknowledge my colleagues in the AACB Working Party on Porphyria. I'm here at the back, and 5 people pictured here are still serving on the committee. This picture was taken in 2012, and I'd certainly like to acknowledge the contribution that they have all had to my education and interest in porphyria. One of the initiatives of the Porphyrin Working Party, which has been in operation since around 2009, is the Quality Assurance Programme on Patient Report Comments. By analogy with the patient report comments in general chemistry, one is supplied with clinical details, some results, and one is invited to comment on the basis of the clinical information supplied and the results. One should assume that a comment has been requested, and the general guidance is to give a differential diagnosis and a guide to further investigation. So for each comment received, this is broken down into keywords or components, which are then circulated to the wider panel for discussion and finally adjudication. For many years, I had the final adjudication, although I have more recently passed this to other colleagues. The elements of each comment are broken down into or adjudicated into what is preferred, considered to add value, less preferred, considered to be neutral, and initially unacceptable, which was potentially harmful or misleading. More recently, however, this has been replaced by two categories: not supported and misleading. We have in the order of 49 participants from 14 countries, and we are now entering our 13th year. This is essentially an educational self-assessment tool, and the expectation is that with regular participation, individuals and laboratories should find they use less unsupported keywords and also feel more comfortable with commenting. And this gives an indication of the global distribution of participants in the RCPA QAP scheme, including patient report comments. So I'm going to draw upon a number of examples of the patient report comments that we circulate through the Australasian Working Party as part of our quality assurance program. So this is the case of a 17-year-old male with a photosensitive rash, possibly present since the age of 10. Urine porphyrins are not raised. Fecal porphyrins are not raised. PBG screening is not detected, thus not acute, but whole blood porphyrins are raised. And there is a plasma fluorescence emission peak, as I mentioned earlier, but this time not at 626, but at 632 nanometers. So the diagnosis here is Erythropoietic Protoporphyria. So this is a photosensitive condition. And the suggested comment included that one should measure free erythrocyte protoporphyrin, ferrochelatase activity, although this is a mitochondrial enzyme that is not easily measured. Typically, in major centers, we undertake mutational analysis to assist to confirm the diagnosis. And LFTs should be monitored as the elevated protoporphyrin in this condition is potentially hepatotoxic. So this is an example of the feedback received with your comment and your keywords broken down, and this is the suggested comment that we've discussed, and there is also a rationale and reference given. The overall keywords are broken down, as I've said before, into preferred, relevant, and at the outset of this program, unacceptable. So for example, the only unacceptable element of the comment here was suggesting liver biopsy, which was clearly not justified on the basis of the information supplied, although may be relevant at some stage in some cases of EPP, but in this context, unacceptable. This set of results also illustrates rather nicely that if a porphyria is genuinely suspected, then you need all the samples, so blood, urine, and feces. So if we had only had urine and fecal samples here, the diagnosis may have been missed. So in this condition of EPP, urine PBG and total porphyrins typically normal, as are fecal porphyrins, although the HPLC profile may not necessarily be normal. There may be a protoporphyrin peak, but blood porphyrins are typically raised, and this is free erythrocyte protoporphyrin. It should be noted that, as I mentioned before, this can be toxic to the liver, and when significant liver damage develops, you can get secondary coproporphyrinuria as part of the condition. So just coming back to the heme pathway, the step involved in EPP is at ferrochelatase, which is the final step in the heme synthetic pathway, where there is incorporation of iron into protoporphyrin to form heme. So when this enzyme is deficient, there is an accumulation, as I've said before, of protoporphyrin. So EPP behaves as autosomal dominant with inheritance of mutation from one parent, but in order to express the disorder, there needs to be co-inheritance of an abnormal low expression allele or polymorphism from the unaffected parent for full clinical expression of the disorder. So this is a depiction of the ferrochelatase gene between exons 3 and exon 4, showing the situation with normal splicing and a T base in this position at -48. However, when there is a polymorphism, a T to a C, there is a reduction in ferrochelatase activity and thus the presence of a low expression allele. This may be present in up to 10% of European populations and by itself is not sufficient to cause the disorder of EPP, and neither is homozygosity for this low expression allele. So you need this plus a mutation on the opposite allele in order to fully express the disorder of EPP. So as I've mentioned, it's a photosensitive condition from an early age. Children usually learn sun avoidance very quickly. You may see dental fluorescence. You can get protoporphyrin gallstones. The treatment is sun avoidance, sunblock, maybe some benefit from beta carotene. Curative, however, is bone marrow transplant with or without liver transplant if that organ is also affected. So here is another case, 25-year-old male, dermatology outpatients, blistering on hands and skin fragility. Total urine porphyrins are raised, total fecal porphyrins are raised, plasma porphyrins are raised. Urine PBG not detected, thus not an acute porphyria, and a plasma fluorescence peak at 620 nanometers, which is less specific. So the hands looked like this with blistering and photosensitivity, so very typical and very suggestive of the condition. So this is a cutaneous porphyria and most likely PCT or Porphyria cutanea tarda, although coproporphyria and CEP cannot be excluded. HPLC profiling of urine and feces would be helpful, looking for typical metabolites, for example, fecal isocoproporphyrin, which would help to establish a definitive diagnosis. Further investigations might include liver function tests and iron studies, as these can often be contributory to the onset of PCT. So these are HPLC profiles, in fact, normal HPLC profiles of urine and feces with the typical expected profile of metabolites that you might see in normals. In PCT, however, where there is a block in this enzyme uroporphyrinogen decarboxylase or UroD, you may expect to see increases in uroporphyrin and the heptacarboxyl metabolite. And in feces, as I mentioned before, we are looking for the peak of isocoproporphyrin, which may be regarded as a hallmark of PCT. So PCT is the commonest, or more accurately perhaps the least uncommon porphyria, with a prevalence in European populations of around 1 in 20,000. Most are sporadic and a minority have a hereditary basis. The sporadic types often occur in males with no family history, multigenic predisposition with environmental factors important, including liver disease, alcohol abuse, hepatitis C, iron overload, including hemochromatosis. The familial type affects both genders with an earlier onset, decreased UroD activity, and a role for family screening. So the affected enzyme is here. This is UroD carboxylase and deficiency responsible for PCT. So the approach to PCT includes, firstly, excluding Variegate porphyria and coproporphyria. Secondly, appraising liver function, testing as appropriate for hepatitis C, ferritin, with or without HFE genotyping in relation to iron overload, treatment involving sun avoidance and sunscreens, alcohol avoidance, venesection if iron overload, or in familial PCT, aiming for low normal ferritin, and in some cases low-dose chloroquine may also help to increase porphyrin excretion. So the next case is a 54-year-old male, also from the dermatology clinic, with skin fragility, blisters and photosensitivity since childhood, scarring, mutilation on hands, fingertips, ears, nose and lips. Urine PBG screen normal, urine porphyrins markedly raised, the uroporphyrin 1 fraction as opposed to 3 fraction, 92% of total, and coproporphyrin 1, 6% of total. Fecal total porphyrins also markedly raised and with a C3 to C1 ratio of 1 in 100. Red cell porphyrins raised, zinc protoporphyrin raised, plasma total porphyrins also raised. This is all consistent with congenital erythropoietic porphyria, or CEP. And the comment recommended that one should consider Euro-S or uroporphyrinogen synthase genotyping to confirm the diagnosis and enable family screening and referral to a specialist porphyria clinic. So this is the condition of congenital erythropoietic porphyria, affecting the enzyme uroporphyrinogen 3 co-synthase, encoded by the gene Euro-S. So this is where the pathway splits into the normal dominant heme pathway involving production of 3 series isomers, and when this is blocked, heme formation is reduced and there is a preferential production of 1 series isomers, which can be detected, as I've shown in the results, which is supportive of this condition. It is a very rare condition, but the Cardiff group and collaborators from around the globe have collated a very interesting series of CEP cases from which you can work through the clinical presenting features, the biochemical results and genotyping. Sometimes it is suggested that CEP, congenital erythropoietic porphyria, is the werewolf syndrome, and I guess some similarities may be made in relation to the scarring and mutilation that you can see together with the marked facial hirsutism, such that this analogy has been suggested. Family screening is the next issue. This can be challenging. The most important aspect is to validate the diagnosis in the index case. Mutation analysis or genotyping may be helpful, especially prepubertal, where other tests are normal, but ideally looking for a known family mutation. Otherwise, screening tests include urine PBG for AIP, which may be raised between attacks. PBG deaminase is the enzyme affected in AIP, but there is significant overlap between normals and affected. Fluorescence screening of plasma looking for the 626 peak may be useful in screening for latent Variegate porphyria, but not always sensitive. And the screening test for Porphyria is the porphyrin 3:1 ratio on HPLC. Management of acute porphyrias includes avoidance of precipitating drugs, intravenous heme or dextrose to effectively offload the pathway. A high carbohydrate diet also reduces the drive on the heme synthetic pathway. In AIP, where perimenstrual symptoms may be dominant, then using gonadotrophin releasing hormone analogues may be helpful. And in Europe and other places, there is interest in gene therapy, and particularly more recently in the use of inhibitory RNA compounds such as givosiran, which is under development, with some very promising results in acute porphyria. In some cases, however, there may be a need for liver and/or bone marrow transplantation, and in the longer term, a lot of patients with acute porphyria are at risk of developing hepatocellular carcinoma and need to be screened and monitored. So how do we know which drugs are safe to use in patients with porphyria or suspected porphyria? And a very useful source of information is through the European Porphyria Network, with the website address indicated at the top. And if you follow the links, you come to selecting a drug. And when you do that, you come to links to unsafe and safe lists. So here is the unsafe list, which includes, as we mentioned earlier in that first case, phenytoin, which induces the cytochrome system. Similarly, carbamazepine. I also mentioned barbiturates, but there is a long list of drugs that are unsafe or potentially unsafe, and that also includes a number of antibiotics, including sulfonamides. And here is an example of the safe list. For example, propofol is safe for use in anesthesia. This was a question that was specifically raised by an anesthetist. Here is another case, a male with abdominal pain, mentally unstable, abnormalities seen on blood film with raised whole blood porphyrins and zinc protoporphyrin, no fluorescence emission peak detected. The abnormality seen was basophilic stippling, which immediately prompted measurement of blood lead. So lead poisoning can mimic porphyria in many ways. It acts by inhibiting heme synthetic enzymes and may present, as I've said, with porphyria-like features, including abdominal pain and encephalopathy. Urine porphyrins and red cell zinc protoporphyrin may be raised, but the easiest way to approach this is to measure whole blood lead. So raised whole blood porphyrins may be seen in lead toxicity, as I've mentioned, EPP, erythropoietic protoporphyria, which we discussed earlier, but can also be seen in iron deficiency anemia, remember the final step in the heme synthetic pathway where iron is incorporated into protoporphyrin. So where that is deficient, then zinc protoporphyrin is increased, and this may also be seen in some cases of anemia of chronic disorder. So key points with respect to porphyria are, although uncommon, be aware that these conditions exist. If you have somebody presenting with acute symptoms in whom you suspect acute porphyria, then urine porphobilinogen, urine PBG is the important test. And if this is negative, then any prevailing symptoms are not due to acute porphyria. And as I said earlier, if porphyria is genuinely suspected, then you should send all samples, urine, feces and blood, protected from light. Finally, if I had to recommend a single reference, it would be this review article from The Lancet in 2010 from the French group, which covers all the elements that I have discussed in the course of this talk and more. Very highly recommended. Finally, as I said in the beginning, I come from Canterbury Health Laboratories in Christchurch, New Zealand. And I'd like to acknowledge two of my key colleagues, Chris Cease and Sandy Woods, who have done the laboratory work that underpins all of the work and outputs that we have produced in the field of porphyria. So I'll conclude at this point, and I would be very happy to take any questions. Thank you.